What is up, everyone? I'm Bo, and I'm back with another high-yield quiz. Today we're going to cover a couple questions covering the gastroenterology portion of the Step 2 exam. So without further ado, let's get started. You can find this on our website at buzzwordsmed.com. So problem number 1, a patient presents with chronic diarrhea, elevated glucose, and malnutrition. What likely histories contribute to such findings? Were they in shipyard work? Were they a Star Wars fan? Do they have a family history of colonic malignancy? Or do they abuse alcohol? Well, I would argue that this chronic diarrhea, elevated glucose, and malnutrition makes me think of a pancreatic issue with the diarrhea, the lack of pancreatic enzymes. Therefore, you'll have that steatorrhea, the fatty diarrhea, and then you'll also have elevated glucose because, of course, your pancreas helps regulate insulin and glucose. So, subsequently, I would think of all these answers, alcohol use would be the best choice. The next question, a 68-year-old gentleman with 2 months of progressive dysphagia and 15 pounds of weight loss presents to you. Which of the following is a risk factor for the most likely diagnosis? Is it processed meats, an underlying coagulopathy, central abdominal obesity, or none of the above? So, processed meats, we think about gastric cancer, underlying coagulopathy. I'm not really thinking of much right now in regards to weight loss and dysphagia. Maybe you could think of rheumatologic things if it was a stretch, or central abdominal obesity. I think that would be the best answer in this case, as those with central abdominal obesity perhaps have more metabolic disease, maybe they have more GERD, maybe that GERD causes the reflux that leads to Barrett's esophagus and subsequent dysplasia, metaplasia, and ultimately malignancy. I think that would be the best answer for someone with weight loss and progressive dysphagia. So, next question. What is the most common cause of gastritis? Is it autoimmune, medication, bacterial infection, or specific food content? I think the most common cause of gastritis is probably a bacterial infection. It's probably H. pylori. I think there's two types, right? There's type A, which is because of that, or type A, which is autoimmune, and then type B, which is bacterial. So this would be probably a type B gastritis or bacterial infection. That would be my answer choice. And we'll see if these are correct at the end. So you have another patient presents with halitosis and regurgitation of food. Which of the following are associated with this condition? So halitosis, bad breath, and regurgitation of food. Is it illicit drug use, history of GI bleed, sex, or age? So it's basically saying which of these can lead you to have something, what is it called, a Zenker diverticulum. So illicit drug use, I'm not sure. History of GI bleed, I'm also not sure. Sex, I'm sure sex has a role. I think it's more common in males. And age, probably when you get older, I would imagine you have more abuse into the esophagus, and that could cause issues as well. So if I was a betting man, I would say sex and age, but we will come back to it and see what the correct answer is. Sometimes with these questions you don't know, you have to do your best, move on, and see if you have time at the end, you can come back. So, next question. We have a patient with 3 months of diarrhea, weight loss, and epigastric pain. You're suspicious of a malignancy and order a secretin stimulation test. What do you expect to happen if your suspicion is correct? So, why do we order a secretin stimulation test? I think those are for gastrinomas, or those cancers that arise in the pancreas that secrete a lot of gastric acid. As such, when you give someone secretin, in theory, it should be inhibiting gastric acid production. In this case, if it is a cancer, it likely will not respond to that feedback loop. So, of all of the answer choices, what do you expect to happen? The answer choices include cholecystokinin will increase, gastrin will increase, pepsid will increase, or pepsid and gastrin will remain inhibited. I think in this case, gastrin will increase, and it's not intuitive, but that's the key, is that normally gastrin would go down, but in these cancers, for some reason, gastrin levels stay the same and or are increased. That would be my answer choice in this person who we suspect a gastrinoma, but we'll come back, of course, and see what the final answer is. A 35-year-old female presents with a broken hip. In the ED, she is noted to be anemic. Review systems is significant for headache and intermittent loose stools. What is the underlying etiology of this patient's fracture? 35 years old and has a fracture. That's pretty strange. You wouldn't expect it in a 35-year-old. She's also anemic and she has loose stools, which starts making me think of a GI pathology. It makes me think of malabsorption. So the answer choices are as follows: paraneoplastic syndrome, GI cancer, granulomatous infection, or vitamin deficiency? I think the answer would be vitamin deficiency. I think this 35-year-old female likely has something like celiac disease and has subsequent vitamin deficiency and diarrhea because of that. Next question. A patient with HIV, non-compliant, presents with severe pain when swallowing. EGD is significant for linear ulcerations near the lower esophageal sphincter. In addition to initiating ART therapy for his HIV, what is best for treatment? Is it nystatin, swish and spit, acyclovir, ganciclovir, or oral fluconazole? So first you need to know what underlying pathogen is causing this, and that would be CMV, right? Because you have those linear esophageal tears, versus HSV, which you'll think of more of like a punctate annular kind of lesion. And if that's the case, if you think of CMV, what is the best treatment of the following for nystatin, acyclovir, ganciclovir, or oral fluconazole? Probably ganciclovir. So that would be the answer that I would choose. All right. Now let's scroll all the way down, let's hit submit, and let's see how those questions, where we have more questions, and we will cover those at some point. I just want to make sure that this video is high yield and quick for those in a time crunch. So central abdominal obesity was the correct answer for those with dysphagia and 15 pounds of weight loss. Those are red flags, remember. You can pause the video here and look at the explanation, but risk factors for this type of cancer include GERD, central abdominal obesity, and a family history of esophageal adenocarcinoma. So, remembering process meats are a risk factor for gastric cancer. Let's skip these because we didn't do them quite yet. Patient presents with halitosis and regurgitation of food. The correct answers were actually age and sex. Older age and male sex, 5-to-1 predominance, are associated with Zenker diverticulum. Good to know. All right. Patient with HIV that was non-compliant, the answer was ganciclovir for their ulcerations, their linear ulcerations near the lower esophageal sphincter. So we got that correct as well. We'll keep going. There's a lot of great questions here that we're kind of skipping for time right now, but next one that we had was the person with 3 months of diarrhea, weight loss, and epigastric pain, and you did a secretin test, and the answer was gastrin levels will increase. So what was the explanation? The patient has symptoms consistent with gastrinoma. These patients typically present with symptoms like peptic ulcer disease, heartburn, diarrhea, and weight loss. Diagnosis of this includes a gastrin level. If that's inconclusive, you can do a secretin stimulation test. Normally, like I said, secretin will inhibit gastrin secretion, but in this case, secretin will actually lead to increased gastrin secretion. Fantastic. We had a 35-year-old female with a broken bone, also with loose stools and anemia, and it was a vitamin deficiency, likely secondary to celiac disease. Let's keep going. There's a lot of questions here. A lot of really high yield stuff on this. A patient presents with chronic diarrhea, glucose and malnutrition. What was the underlying history? And we said alcohol use, remember? And that's right, because they had chronic pancreatitis. Risk factors include alcohol use, recurrent acute pancreatitis, alpha-1 antitrypsin, and gallstones, to name a few. All right, I think that is it for the questions that we covered. I'll cover the rest in a subsequent video and a subsequent episode. Until next time, check out everything we have at buzzwordsmed.com, and feel free to check out all the YouTube videos, all the high yield stuff that we have coming your way. Until next time, have a fantastic day and a great rest of your week. Bye-bye now.